Thanks everyone for joining and welcome to the first session of the Ohio State University Nighsonger Center ECHO on mental health and intellectual and developmental disabilities, putting knowledge into action. Quick overview of today's agenda will include introductions from our core team or hub members and an introduction of the ECHO model and technology. I invite all of our participants as we're doing that to introduce yourself to others in the chat. Your name is already present, so you could list your title or role in the organization that you're with so we can start getting familiar with who's all with us today. You can see we'll have two main items on the agenda, including a didactic presentation and a case presentation as part of our session today. At this time, we'll go through introductions of our core hub team that's leading this ECHO series, and we'll start with Dr. Andrea Whitwer.
Hi, everybody. I'm Andrea Whitwer. I'm a psychologist at the Nighsonger Center, and I'm excited to be with all of you here today.
And my name is Andrew Buck. I'm a research scientist and will be serving as the facilitator for our ECHO series. Manisha?
Hi, everyone. Thank you for joining us. I am Manisha Khatirda, and I'm the clinical research coordinator working on this project. Justin Wallace.
Hi, my name is Justin Wallace. I am a clinical research coordinator here at OSU.
Erin Harris.
Hi, I'm Erin Harris. I'm a clinical social worker at the Nighsonger Center. It's nice to see everyone.
Kelly.
I'm Kelly Barnett. I'm the program manager at Nighsonger Center Clinical Support Services.
Lynn.
Golly, I'm having a whole lot of issues with technology. Sorry, guys. I'm Lynn Anderson. I am one of the senior clinical behavior specialists with Nighsonger Clinical Behavior Support Services.
Patricia.
Hi, I'm Patricia Berger, CEO for Empowering Integrated Care Solutions, and our agency serves individuals with intellectual and developmental disabilities, as well as mental health issues.
Marianne. Marianne is available with us today. We'll come back. How about Nicole?
I am Nicole Lowe. I'm the DD clinician at NetCare.
Meredith? Durga?
Hello, thank you for this opportunity. My name is Durga, and I'm a community health worker working at Ohio Disability and Health Partnership, and I'm so proud of this part of this group. Thank you.
Cindy?
I'm Cindy Nava. I'm a compliance and benefit coordinator with Grand County Board of DD and a parent of an individual who receives DD services in our county.
Lauren?
Hi, my name is Lauren Shepler. I'm a disability advocate. I'm an individual with a disability, and I'm excited to be part of this group. Thank you.
Robin?
Hi, my name is Robin Tierney. I'm the MID coordinator for the Lake County Board of Developmental Disabilities.
Kate?
I'm Kate Taylor, supervisor for Franklin County Board of DD Service Coordination Department.
And Chris?
Hi, I'm Chris Watts. I'm a clinical social worker at the Cuyahoga County Board of DD.
Okay. Thank you, everybody, for sharing. I'm going to reshare our slides and go through some introductions on the ECHO model. Again, in the meantime, if you're just joining us, you can feel free to tell us a little bit more about yourself in the chat. As you can see, we have a great interdisciplinary team leading the charge, and we're really excited for you all to join this team and collaborate with us on this initiative.
Hey, Andrew, it does look like we have a few other folks that have joined from phone. I don't know if it's okay if I take a minute just to ask them to identify themselves so we make sure we get them renamed.
Yes.
Okay, the first one is a guest with the 614 area code. Oh, hold on. That ends in 081. If you could unmute yourself with *6 and give us your name, we'll be able to rename you.
Carla May.
Carla May, and what agency are you from, Carla?
Franklin County Board of DD.
Perfect. The next person is also a 614 that ends in 523.
Trinity Wolf, Franklin County Board, DD.
And then we have a 937 that ends in 000.
Hello, can you hear me?
Yes.
Oh, good. This is Michelle Sayer. I couldn't get the Zoom link to work, so I am calling in, and I'm from CareSource.
Great, thank you. All yours now, Andrew. Thank you.
Thank you too. So we're all joining this collaborative project that's known as ECHO, and ECHO stands for the Extension for Community Healthcare Outcomes. And you'll get a feel for the nuance of that acronym ECHO as we talk a little bit more about how this interdisciplinary community of practice works, in which professional networks come together to teach and learn from one another. And so we're teaching and learning and kind of sharing our voices, and it's highly encouraged that you participate as an active member of this group, because your expertise and your perspective is invaluable to helping others across different contextual settings. In ECHO, it consists of a short didactic lecture as well as a case presentation that's conducted during recurring video conferences. This is our first session. Over the next several weeks, holding other learning sessions as we come together and work on this as a team. We do encourage our participants, if you're interested in being a presenter, whether on a didactic presentation that's up to 20 minutes or as a case presenter, to give us a specific case. We highly encourage you to think about that and consider that as one way to be a really active member of this group. We'll get to learn a little bit more about the presentation and case presentation format through this session today. Participants in this ECHO series really learn best practices to support individuals that they serve by implementing real-time solutions that improve systems and remove barriers to care. And again, that goes back to that extension of community healthcare outcomes by removing barriers to specialized knowledge. Outcomes for students, patients, and families can be improved across settings and across Ohio. ECHO is an all teach, all learn model. And the heart of the ECHO model is its initial hub, as we introduce ourselves as the hub, and spoke knowledge sharing networks. And so all of our participants today are considered spokes of this central hub that are really important in helping us to share information that's interdisciplinary across different contextualized settings. So case-based learning and mentorship is really key to the ECHO model and supports local professionals and communities to gain the expertise that's required to provide unique specialized services. Our ultimate goal here is to build a community of practice with one another. Another aim is for all participants to gain the skills and confidence while learning about new approaches for applying their knowledge across diverse cultural and geographical contexts. So we highly encourage you to contribute to the meaningful discussion, to actively engage, to open your mind to diverse views, to lead by example, and also to maintain confidentiality as we're talking about our own personal experiences. As you know, we are recording these sessions, so please keep confidentiality in mind as well. We will have a post-session evaluation that will be presented at the end of this session and also included in the chat at the end, as well as a follow-up email. The evaluations are mandatory if you're seeking continuing education credit. Even if you're not seeking continuing education credit, we encourage you to submit your perspective on these evaluations to support our process evaluation and improvement, and it also supports our longevity and funding for future ECHOs. It's important to note that Project ECHO also we collect and utilize administrative data that's related to ECHO programs to support back to a database, and that is de-identified as well. In some examples here, you can see our number of participants and maybe other types of demographics that you included in your registration. At this time, I want to welcome to the stage Lynn Anderson and Andrea Whitwer as we delve into the first didactic presentation of our ECHO on mental health and intellectual and developmental disabilities. And today's title is Identifying Mental Health Symptoms in Adults with Intellectual and Developmental Disabilities, Strategies, Tools, and Resources. Our presenters are Lynn Anderson, a licensed independent social worker with supervision designation for Nisonger's Clinical Support Services, and Dr. Andrea Whitwer, the Director of Training for the Nisonger Center, a Lind Co-Associate Director, and IDD Psychology faculty. Lynn and Andrea.
Thank you so much, Andrew, for that introduction. Lynn and I are really excited to talk with you all today to kind of kick off the session, if you will. So our plan, oh, if it'll let me click. Our plan is really to outline the ideas around identifying those mental health conditions in adults with intellectual and developmental disabilities. So between the two of us, we're going to describe the different roles that team members can have in identifying mental and behavioral health concerns. From folks that are with individuals every day, like direct support professionals, SSAs, clinicians, etc. So talk about some screening tools that can be used across different levels of cognitive functioning and considering different communication abilities. Talk about some preventative environmental strategies to promote mental health, and identify some resources in your community. So just to give us a little bit of framing, you guys are all here because you know this is an important issue. But when we think about the scope of that, we know in the literature that anywhere between 10 and 60% of adults with intellectual disability have mental health problems. We know they're 3 times more likely to experience depression. And we also see high rates of anxiety disorders as well as others. For autistic adults, we see even higher rates. So autistic adults have over a 5 times greater odds of having at least one psychiatric diagnosis as compared to those without developmental disabilities, and even almost a twice as likely odds of having one compared to others with other types of developmental disabilities. And you can see there most common things like ADHD, depressive disorder, anxiety, social phobia, and substance use disorder. And this addition of mental health concerns for adults with ID does have really significant impacts on life. When we think about exclusion from daily activities, we see increased emergency service usage by folks that have this mental health concerns. increases in parental or caregiver stress, use of psychotropic medications, and polypharmacy. And we will look at all of those together. Those other risk factors can lead to poorer long-term outcomes and functioning for the individuals. So it's a really important issue that we need to take care of. But often we hear when we talk to service providers that we operate in these siloed systems where we have mental health and we have disability, and there's not always this overlap in symptoms. I'm so excited, hence, to have all of you there. You saw we have folks that are from mental health agencies, so they're introducing themselves, and social workers and County Board of DD staff to really think about how can we work together to meet the complex healthcare needs that our folks have to really help support their mental health. This is a slide and a term you're going to see twice during our presentation. Lynn, when we were going through the edit, she's like, you have the slide in there twice. I'm like, I know, it's an important slide. And you're going to hear Dr. Cooper talk about this idea of HELP, H-E-L-P. So if you look on here, health, environment, lived experience, and the psychiatric disorder. Our adults with IDD are, just like with everyone else, we need to be thinking about all of these things when we're supporting their mental health. We need to think about their physical health, their environment, the difficulties they're having with their supports, their expectations, whether they have the ability to make self-determination, lived experience, and psychiatric disorders. While also, if you look on the other side, considering things like strengths, vulnerabilities, what's going on in their lives. So it's a really complex thing that we need to think about as we're supporting that mental health of our adults. And that's why it's really important that we think of this from a team approach. So we're going to spend a little bit of time today talking about what psychiatric symptoms look like, but also more, how can you as one of the team members kind of look at what your roles could be and understanding what other roles on the team can be. So all of these folks are so important, and so many others. I realize this is only a short list of the teams that some folks have, but we think of that team as the individual themselves, their parent, caregiver, guardians, providers, educators, other support staff and professionals, as well as natural support. So we want all of those folks to work together. It's important because I said, got this complex little graph that we're working on, but it's also important when we look at some of the literature, we'll often, we talk about there's difficulty identifying and recognizing mental disorders, which can be a barrier. But then we also think about often adults with IDD are not in a place where they have the opportunity to access services and supports for those psychiatric symptoms. They're on their own. Often they're relying on carers or support people to help with that identification and linkage piece, which is problematic because when we interview and talk to mental health professionals, there's often a belief, and they report this belief, that family members will often not seek that help until it comes to a critical point. So I've been in lots of meetings with others where we're talking about crisis intervention. When we get folks that are in crisis, we need to know how to address their needs, but we also need to understand and recognize those difficulties before we get to that point of crisis. And that's really where this team approach can come in. So recognizing symptoms, challenging. We're going to dig into that. Lots of you who work with folks with IDD already know that. I'm not telling you something you don't know. But I think it's also important to understand some of the stuff that's at play with the ones is diagnostic overshadowing. So this is a term that we often have talked about when we talk about clinicians and doing diagnosis, but it's something that we're all have the potential to fall victim to. And it's this idea that all of the difficulties that an individual is having are just attributed to their intellectual and developmental disability. So saying, well, the person is crying and isn't engaged in social activities, that's because they have an intellectual disability. It's not, we shouldn't be considering depression for this person. So really trying to kind of put, the person is engaging in self-injurious behavior. Well, that's because they have an intellectual disability. No, not everybody with an intellectual disability engages in those behaviors. Those behaviors can be a symptom of some type of a psychiatric disorder, another mode of someone communicating to them. So these are important things for us to realize. So it can impact getting someone in. So it may impact someone diagnosing them, but it can impact a direct support professional or a service coordinator or a family member, just attributing all those difficulties to the diagnosis and not seeking treatment for something where the individual could get relief for. It also can impact how we conceptualize the case and seeking other treatments. So we want to realize things like depression and anxiety, there are emerging treatments that we can use for adults. And we want to make sure that we get to those. And that's why it's really important that we have coordinated care at each of these different steps that we're going to be talking about over the course of this. So thinking about today, we're going to talk about that symptom identification part and really how can we do this? And it's really about everyone paying attention and sharing their concerns that allows us to catch that early. So what could that look like? We think about depression. As a clinician, I have a checklist that I go through, but there are a lot of things that folks can pick up on that are observable things that we can see. We see crying, increase in crying, a decrease in appetite or an increase in appetite or sleep, decreased participation in adaptive skills, decreased interest in activities that folks used to like, a slowing down of their motor movements. When we look at those things, if we see a change in baseline and tracking how long that's going on, that's something that everyone that interacts with someone can track and be able to report and really start to talk to the team to see, is there something else going on? Same thing goes for anxiety. This might come up as someone worrying a lot about upcoming events, repetitive questioning, reassurance seeking, some of those physical signs we see with folks with anxiety, difficulty falling asleep, being extra jittery, increased fidgeting from normal, being very clingy to other people. So you can see some of these things are things that you would be able to observe and maybe just raise at a doctor's appointment or with clinicians to really help with that identification of symptoms. So when we think about this whole trajectory, we've got these concerns. So I said, okay, we've got these concerns that we've seen. So then how do we move through this table and what are the roles of the different folks that are involved potentially in someone's team? I'm going to turn it over to Lynn now, who's going to walk us through some of those roles, starting with the direct support professionals and caregivers.
Thanks, Andrea. So DSPs and caregivers are individuals who are going to be spending a large period of time with individuals who have disabilities. And so we really need them to be paying attention, and we really need them to feel comfortable communicating with the team as well. But things that they can pay attention to are changes in appetite, sleep, hygiene, mood, behavior, anything like that. And then if they can report those to the team, or if they're the individual who attends provider, the psychiatry appointments or anything like that, making sure that the provider is aware of those things that they're seeing. Reporting kind of any changes that they notice to the team. They definitely can help ensure that appointments are scheduled and attended. Some individuals like to do that on their own, and that's awesome. Some of our individuals are not able to do that on their own. They need that assistance, or at least someone to help remind them when an appointment is coming, or to get them to or from an appointment. And also really advocating with or for the individual. I think as much as we can, getting someone to speak up for themselves is absolutely best. But there are a lot of people out there that don't feel comfortable doing that at all, or don't feel comfortable doing that on their own. So being that individual that kind of comes in and advocates with them or for them is super important. So ways that you, if you're a DSP, can do that, or a caregiver, you can certainly track behavior. Data collection is really, really helpful, especially when you're going into an appointment. Instead of just saying, well, their sleep seems different, they're gonna want more details than that, right? So you can do a sleep chart, a hygiene chart, nutrition. You can track all sorts of behavior data that way. And you can do it any number of ways. You can do, like for sleep chart, you can just have someone, you list out all 15 minutes of every day and you color in when someone's sleeping, right? Or it could be something like a hygiene chart could say, did they complete this hygiene task? Yes or no. so that we're getting kind of a frequency. When you're doing behavior data, you might want to get more into like antecedents and behaviors and the consequences of those behaviors instead of just a frequency count, because sometimes frequency isn't really indicating the need. For example, I have a client, they don't have behaviors very often, but when they do, it's go big or go home. And so it's really, really serious. So making sure that we explain that, yes, they've only had one behavior in 3 months, but that behavior was incredibly dangerous is important. Places you can get additional information, certainly DODD, they have a lot of great information on there. National Alliance on Mental Health has great information. There is the MHDD Training Center. There's a National Center on IDD. And NYSONGR Clinical Supports can also assist in giving you information and helping you to understand kind of what's going on. So as a caregiver or a DSP, especially DSPs are going to be working with a lot of different individuals. It's great if they can learn kind of about the symptoms of different mental health diagnoses, especially the diagnoses for the individuals that they're working with, and the most effective ways to communicate with that person. If you know someone has bipolar disorder and that when mania starts, it can get pretty serious pretty quick, then knowing that if someone's not sleeping for multiple days at a time, but they still seem like the Energizer Bunny is going to be really important, because you're going to need to be the one to call and say, hey, this is what I'm seeing. Let's make sure that we get this individual into an appointment quickly. Like I said, attending appointments is great. Ensuring that medication is used appropriately. If the individual needs assistance with medication, there are plenty of people who do not, and that's great. Also helping to make sure prescriptions are filled on time. We certainly want to protect the rights of the individual as well. They have a right to go into an appointment on their own if they'd like. That doesn't mean you can't speak to the provider. You can send a message privately. You can ask to speak with them briefly after an appointment, anything like that. And there are a lot of crisis prevention and intervention training courses, things that will kind of help you catch things early. The earlier we can intervene, generally the better things are going to be. For a lot of you who are service coordinators here, one of the things you can certainly do is to assist in finding mental health providers, especially knowing mental health providers that work with individuals who have disabilities, because they're going to have a better understanding of kind of what we were talking about earlier. Is this a symptom of their mental health, or is this something else? You can certainly ensure that their OISP has very up-to-date information about their diagnoses and what individuals who are working with them should be looking for, because a lot of times they don't have time necessarily to do the research on their own. And I know it's something that we suggested, but they don't always have that opportunity. So giving them the main symptoms for this particular individual, because depression looks different for different people. What does it look like, for this particular person that you're working with? These are the things that you should be looking for. You can certainly find supportive services in the county. That can include things like AA. We've got NetCare, we've got Adam H, counselors, anything like that. You can certainly make referrals for behavior support if it's needed or if you think it will be helpful. Can definitely support DSPs and caregivers in providing really trauma-informed personal care, helping them understand how to approach the individual, how to make sure that they're supporting the individual. And then you can also help the team with doing some crisis planning ahead of time if you know that these things can and have occurred. I am not going to go through all of these tools and resources. There are a lot of links and things that you can look up, and I'm confident that you can all to read the sites, but there are some really, really good ones on here, especially the ones here in the state of Ohio. Just taking a look at those, especially so that you've got the resources that we have here in our state, is great. Sorry, Andrea, I made you go backwards. SSAs, they can certainly meeting with the team and the individual regularly, and being able to observe them in different environments. If you've always visited in their home, maybe the next time you go to visit, go see them at day program, because I know I am very different at work than I am at home. Most people are different in different environments. So kind of getting an idea of what that is for different people. Definitely familiarize yourself with those general symptoms of mental health diagnoses. You can share that knowledge with the team. Not everybody on the team is going to know, hey, if this person isn't doing their hygiene activities, it may not be because they just don't care if they smell bad. It might be because they're depressed and they can't get the energy to do that. And you can be the one to say, hey guys, this is something we might want to consider for this individual. I think everyone on the team, you'll hear this again and again, advocating for them or assisting other individuals on the team is important. SSAs really being able to familiarize themselves with the different practitioners in the community or the programs in the county, things that are offered, not just AA, not just mental health. Is this an individual who needs some assistance, like a healthy relationship course? Would that be beneficial for this person? Or do they need an internet safety course? Where can I help them find those things? If you know those things already, it's easier to go ahead and present them as quickly as possible. And then of course, and no SSA is going to be happy to hear me say revising the LISP as needed. But it is important because that is what those in the house are using to know what they're supposed to do. So the role of the mental health professional, they're going to use standardized measures to assist for mental health conditions. They can definitely support family, staff, caregivers in collecting information on presentation of concerns, implement or connect evidence-based treatment. The thing to understand is it's not like, for me, for example, as a behavior specialist, it's not my job to diagnose someone with a mental health disorder, but it is I don't even want to say job, it's my responsibility to help report and advocate for that person. If I'm seeing symptoms of a mental health disorder, being able to speak to the team or speak to their practitioner or even to the individual if it's something that they can handle discussing is really, really important. So there are a lot of psychoeducation. There's different presentations, sorry.
Yeah, I can jump in too on this.
I was going to say, I think I went past my slides and I can't.
You did, but you were just
so sorry. I was like,
you were doing great. So I was just going to sit back and let you do it, Lynn. So from the psychologist's perspective, I think having that psychoeducation on the presentation of mental health conditions and looking at that psychoeducation for yourself and then providing that to the individuals with IDD, their family and the direct support staff, that helps. When you can educate them on what to look for, then they can help you. Often we may assume that they may know what depression or anxiety is, but they may not. So it's important not to make that assumption, and then really providing suggestions on all the things we've listed above when it comes to the psychoeducation, and then working on implementing evidence-based treatments, which we'll follow up with. I have some resources here. There are some standardized assessments that can be very helpful that work for folks who have mild to moderate intellectual disability. Those are the Glasgow Anxiety and Depression Scales. There's a great adapted PHQ-9 and GADS, which are what primary care physicians. And then the National Association of Dual Diagnosis has the DMID-2, which helps to translate psychiatric DSM criteria for individuals with ID. We also have some great practice guidelines that have assessment in them that I will make sure I update and put the link in there when sharing those. And then have some other additional educational resources for you all to look at your leisure. And we'll pause. I know Andrew said we're short on time, but hopefully, Andrew, we have time for a few questions.
Yeah, thank you so much, Andrea and Lynn, for that presentation, especially during our first session here as we're kind of working through some of those technical difficulties in the flow. I didn't mean to rush us through, but I did. A really important part of ECHO is the community engagement. And so I'm wanting to open it up to questions from the group as you were hearing a little bit more about these strategies, tools, and resources to identify mental health conditions amongst the population. Were there any questions that arose for you that you would like to ask, or anything that you would just like to reemphasize? And You can add anything in the chat if you like. You can also raise your hand on video, and I'll scroll across the videos, or you can use the reactions button at the bottom of the screen. Any questions from our group? As you're thinking about that, let me pose a quick question to the group. Something that really caught my eye at the beginning is, and something you said, Andrea, is that this population is 3 times more likely to experience mental health conditions. And there was a range presented from 10 to 60%. Can you readdress why that's problematic and why this ECHO series targeting these strategies, tools, and resources are important, and what we really hope to get out of this to address that problem?
Yeah, I think that is a great point. And I think the short answer is we're still not that great at identifying mental health conditions and assessing them. So the rates that we get depend on, in the research, just depend on how they're assessed, how they're characterized. And some of it is whether we ask a support person or the individual with intellectual disability themselves. So that's why it's so important to kind of use as much information as we can, because I think that's what you'll see is that there's not, everyone's approaching it maybe from a slightly different perspective when they're making those diagnoses.
Great, thank you. There are a couple hands raised and a question in the chat. I'm going to ask the chat question first, and then we'll move to Renee. In the chat, Amy writes, is there a credential that allows me to know if a person has any specific training or skill in working with the IDD population?
Yeah, that's a great
from a mental health perspective, sorry.
Yeah, that's a great question, Amy. And yes, there is. So NAD, or the National Association of the Dually Diagnosed, has a clinical certification for individuals that they have to go through a pretty intense examination and rigorous kind of vetting of their training to see that to demonstrate that they have that competency. So for example, I'm a NAD certified clinically certified clinician. They also have them for agencies. Agencies can go through it as well as other providers. So I think that's an accreditation that you can look for. And I believe that NAD they have a number of resources on their site. I'm not sure if you can search for clinicians, but there's definitely more information on that. And I can, after we finish answering questions, I'm happy to put that link in the chat.
I just want to add too, because sometimes you might be in an area where you don't have a lot of options and maybe they don't have those qualifications. If you're someone like a service coordinator or something of that nature, really utilizing the other service coordinators that you have is important. Knowing who they've worked with in the past that has had success with individuals that they've served is another helpful way to get more information on that if you don't have someone that meets some of that other criteria.
Thank you. Renee.
Hey, I just have actually a question for the future. I'm not sure if you guys can answer it, but just knowing, like going through clinical courses for my social work degree, there wasn't really much presented on the population of IDD and the integration of mental health. Is that something that maybe the state of Ohio will look towards to develop some curriculum to help our newer, clinicians that are going to be working in the field?
Oh, your question is music to my ears, Renee. So we have a Rehabilitation Research and Training Center grant. And as a part of that and some of the other work, so Nighsonger Center does a ton of clinical training. So we've been really trying to start the advocating process to look at clinical competencies that different professions are doing and seeing how we can integrate into from the pipeline of folks to go forward. So I'm a psychologist, so that's where I've been starting, is really trying to advocate, and there's definitely a will for that nationally. And I know that some of our social work faculty and I've had conversations too about that. The other thing is just looking at some of the LEND programs that are out there leadership education and neurodevelopmental disability programs. So we have 2 in Ohio that do provide some of that training. But yeah, I think it's something that we're hoping will continue to keep pushing the envelope on.
Awesome. Awesome. Thank you for that information.
Yeah, thanks for the question, Renee. Durga.
Alrighty, so my question is like based on my experience working with the population with the IDD. So my question is like what we could like or how we could help or support if a client is not willing to discuss their mental health status, even they are experiencing and we have been observing in our daily basis.
So this is something that I actually see a lot in the teams that I work with. They either don't want to or are not able to, right? And I think that's where, as a team, we really have to become the advocates. I have an individual on my caseload who has a pretty severe psychotic disorder diagnosis. And she's not really one who's going to be able to advocate for herself. But what was happening is we'd finally kind of found a group of medications that was doing what they needed to do to kind of help her live as successfully as she possibly could. And this is an individual who had massive amounts of restrictive measures in their supports. And we were able to fade a lot of those things because she was doing so well. But what also happened is she got a shaking in her hands, probably as a result of the medications that she was on. And so her doctor decided to reduce the medications. As a team, what we were watching is that, they reduced the medication, but in doing so, her quality of life, her ability to have clarity of thought was significantly compromised with that change. And we also noticed it didn't change the shaking in her hands. And so as a team, we actually met with her psychiatrist multiple times to really advocate on her behalf that he put her back to what was the most therapeutic dose of that medication for her. And it took a couple of sessions of meeting with her, and it took not just one of us, but we worked together as a team, the behavior specialist, the service coordinator, the provider. We all went in together to really advocate for that individual. And she's doing really, really, really well now. So.
Thank you. With just a little bit of time left, let me move us into a quick lightning round response, because there's a couple other questions that I'd like to address, and maybe we can expand on them as we kind of reflect on this recording and readdress these questions. Maybe we can start a frequently asked question list to kind of expand upon these great questions. But in the chat, we have a couple other questions. So maybe just some quick responses, Andrea and Lynn, as we move through and then try to get to our case presentation. Tara writes, are there any initiatives to increase the interest in working with people with ID among psychiatrists and psychologists? It feels difficult to access care that is appropriate.
I'm not aware of any, but I think there are lots of folks that are trying to recruit and train in that area, but I'm not aware of any specific initiatives.
Next question is from Tyler. I'd love to hear some tip for phone screening to determine level of ID and whether the assessment is appropriate to complete with the member versus a support person or caregiver.
That is a great thing that I know that our research team has worked on related to other things, and I'm not sure, but how about I report back to you next week?
Great. Next question is, do you have visual mental health assessments screenings for people with developmental disabilities that do not communicate with words or that English is not their first language?
I put a link in here to an example of one that has pictures with it for the anxiety and depression screen. And we also are working at NYSONGR to have a full diagnostic instrument that will use pictures. It's not quite available yet, but we will definitely share among the community when that is done.
Okay, great. So I'm looking to my hub team to see if our case presenter has been able to join our session to move forward. In the meantime, while we're confirming that, again, I want to give thanks to Andrea and Lynn for sparking that great discussion. I think we'll really consider how we can best utilize these resources.